Good morning, everyone. Our topic for today is gingival surgical techniques, gingivectomy. We'll also be discussing gingivoplasty along with gingivectomy in this topic. So, when a patient comes to us with a periodontal pocket and we have to manage this pocket, so what we usually do is we go in for scaling root planning, supra and subgingival debridement, oral hygiene instructions. This is followed by re-evaluation of the patient at regular time intervals. And during this re-evaluation phase, if the pocket is still persistent, then we can go in for either pocket elimination procedures or for pocket correction procedures. Now, if we go in for pocket elimination procedures, it can be gingivectomy or apically repositioned flap with or without osseous surgery. So these things, they completely eliminate the pocket. Whereas on the other hand, SS flap surgery like the Kirkland flap or the modified Woodman flap or the ENAP procedure, excisional new attachment procedure, the replaced flap, or any type of regenerative surgery, it causes a reduction in the pocket. It does not eliminate the pocket, and this reduction is usually due to the shrinkage after removal of all the retents and the pocket lining. So after this, also patient is kept on the supportive periodontal care, and again he is re-evaluated at timely intervals to see if the pocket is progressing or not. Now coming to the definitions, gingivectomy, as the name says itself, it means excision of the gingiva, whereas gingivoplasty is reshaping of the gingiva to create physiologic gingival contour, with the sole purpose of recontouring the gingiva in the absence of pockets. So, for example, in case there is a gingival polyp on the facial aspect of the attached gingiva, so if you remove that polyp, uh, that won't be affecting any sort of sulcus or the pocket. That is known as gingivoplasty. But if you are excising the gingiva and that has something to do with the sulcus or gingival sulcus or the periodontal pocket, then gingivectomy is the term that is used. Gingivoplasty is mainly for the aesthetic corrections. Now coming to indications of gingivectomy. Gingivectomy, first and the foremost indication is elimination of suprabony pockets regardless of their depth if the pocket wall is fibrous and firm, because see the edematous and soft pockets, they require scaling and root planing. But even after the scaling and root planing and removal of all the retents, if the pocket is still present and it is firm and fibrous, then gingivectomy is done. And it can only be done in suprabony pockets. It is not possible in infrabony pockets, because in that case, if you go in for gingivectomy, your incision will strike on the bone itself. So that is not possible. The second indication is elimination of gingival enlargements, and then it is elimination of suprabony periodontal abscess for all types of like drug-induced gingival enlargements or hereditary gingival enlargements or idiopathic gingival fibromatosis, or even after the inflammatory component of the pocket has subsided, if it is still there, enlargement is present, then we go in for this gingivectomy procedure. See, as you can see in this photograph, in the top picture, it shows that when the pocket is suprabony, only then gingivectomy can be performed. In an infrabony pocket, as I said, your scalpel will strike on the bone itself, so that won't be possible. Now coming to contraindications of gingivectomy. The first contraindication is need for bone surgery or examination of bone shape and morphology. So if you need to examine the bony architecture or the type of bony defect there, gingivectomy cannot do this thing, because gingivectomy simply removes the soft tissue. It traverses the soft tissue. It never reaches the bone. So you cannot examine the bone shape and morphology. A second contraindication is situations in which bottom of the pocket is apical to the mucogingival junction. The mucogingival junction is the junction between attached gingiva and the alveolar mucosa. So if the pocket is apical to the mucogingival junction, so in that case, your pocket lies somewhere in the loose or the alveolar mucosa or the lining reflecting mucosa. So since this gingivectomy is done in the attached gingiva, so when attached gingiva is absent, so definite, but obviously gingivectomy cannot be done. And third is for aesthetic considerations, particularly in the anterior maxilla. See, in anterior maxilla in young patients, especially in female patients, even if there is a persistent pocket and uh, that is fibrous and firm, and it needs to be eliminated. But if it is going to create a aesthetic consideration, it is going to create an aesthetic scar in that area. So you won't be going in for gingivectomy in that case, because you in that if you go in for gingivectomy, you definitely will improve the function, but the aesthetics will be gone. That is the prime concern in the anterior segment. No, gingivectomy can be done using surgical. It can be done surgically or by electrocautery or by laser gingivectomy, or gingivectomy can be done with chemosurgery also. Most common is the surgical gingivectomy. Step one is the pockets on each surface are explored with the periodontal probe and marked with the pocket marker. Pocket marker is an instrument that resembles somewhat it's in form of a tweezer, where one beak of the tweezer has a pointed end. So if you clip it, it will puncture the outer aspect of the gingiva and will mark the pocket. That is why it is known as pocket marker. So each pocket is marked in several areas to outline the codes. So you create several many bleeding points. So along that you can excise the pocket. The periodontal knives like Kirkland knives and Orban knives are used for incisions on the facial and lingual surface, and those distal to the terminal tooth in each arch. Whereas periodontal knives are used for interdental incisions, and Brad Parker blades 12 and 15, as well as scissors, are used as auxiliary instruments to remove the granulation tissue and detach the gingiva. The incision is started apical to the point marking the course of the pocket, directed coronally to a point between the base of the pocket and the crest of bone. So this is also known as, specifically, I can say it is known as external bevel gingivectomy. This direction of scalping, excising the pocket. And as I told you in the contraindication that it is done only in the attached gingiva area. So this first point is what I was saying. Second is either interrupted or continuous incisions may be used. The incision should be beveled at approximately 45 degrees to the tooth surface and recreate the normal festoon pattern of gingiva. Thin scalloped festoon pattern of gingiva should be achieved. And step 3, remove the excised pocket wall, clean the area, and closely examine the root surface of all the granulation tissue, all the calculus section. Everything should be removed. Carefully curate the granulation tissue, remove any remaining calculus and necrotic cementum to leave a smooth and clean surface. Step 5 is cover the area with a surgical pack. You can use a co-pack or any periodontal pack for that matter, so that it does not irritate the exposed gingival tissues. Now, periodontal knives, first knife in the picture is Kirkland knife, and second is the Orban's knife. In this diagram, it is shown that pockets are probed with the periodontal probe and marked with the help of pocket markers. Several bleeding points are created as we were discussing. And then in the second picture, the operator is using a continuous incision, which is directed coronally somewhere below the bleeding point, directed coronally below the base of the pocket. The second in the A and B picture also the same thing is shown. Now in this slide, the first picture is of discontinuous incision and second is of continuous incision. Both can be done according to the convenience of the operator. And then you simply remove the excised tissue and you apply the co-pack. After removing the excised tissue, then you clean all the surfaces of all the plaque, calculus, and any irritant that is present, and then you place a co-pack over it, a periodontal pack. This picture also demonstrates the same thing, that the excise after the excision of the large gingival tissues, and B figure shows use of Kirkland knife on the facial aspect, and then in the C figure it shows Orban's knife detaching the gingival tissues in the interdental area, and then there are bone nippers, the tissue nippers that are used in slide D, and then you are correcting the tissue with auxiliary instruments, and finally after all the debridement, periodontal pack has been placed in figure G. This is the figure H is the post-operative healing. Now, gingivitis can also be done by electrocautery. Advantages are it controls the hemorrhage. There is very less, or you can say no bleeding. And adequate contouring of the tissues it can be done. But disadvantage is it cannot be used in patients who have poorly shielded cardiac pacemakers. Now nowadays, pacemakers are usually very properly shielded, but in earlier days, pacemakers were not properly shielded, and it can cause the electromagnetic interference in such patients. A treatment causes unpleasant odor. There's a lot of smell in this. If the electrocautery point touches the bone, irreparable damage can be done. And it also can injure the cementum area. It can burn the roots of the teeth also. So heat generated by injudicious use can cause tissue damage and loss of the supporting periodontal tissues. The electrode is used close to the bone. When electrode touches the root, areas of cementum burn are produced. The technique is removal of gingival enlargements, and gingivoplasty is performed with the needle electrode, and small ovoid loop or diamond shaped electrodes are used for festooning the area. In all reshaping procedures, electrode is activated and moved in a concise shaving stroke. You can see this thing being performed in this figure. The second figure, we are using the needle electrode, and finally Copac has been placed. Coming to laser gingivectomy, lasers most often used in the industry are carbon dioxide and NdYAG with a wavelength of 10,600 nm and 10 and 1064 nm respectively. The healing is delayed compared with healing after conventional scalpel gingivectomy. Requires precautions to avoid reflecting the beam on instrument surfaces, which could result in injury to neighboring tissues or eyes of the operator. So that is the main concern. You have to be very much cautious while you are using lasers for any procedures in dentistry. Now coming to healing after gingivectomy. Initially, there is formation of a protective surface clot. This is followed by underlying tissue becomes acutely inflamed after any trauma. There is acute inflammation with some necrosis. The clot is then replaced with granulation tissue. By 24 hours, there is an increase in new connective tissue cells, mainly angioblasts, below the surface of inflammation. By the third day, numerous young fibroblasts are located in the area. This is highly vascularized connective tissue, grows coronally, creating a new free gingival margin and sulcus. After 12 to 24 hours, epithelial cells at the margins of the wound start to migrate towards the granulation tissue. The epithelial activity reaches peak in 24 to 36 hours. After 5 to 14 days, surface epithelialization is generally complete by, you can say, about 2 weeks time. And complete repair of all the tissues, all the connective tissue and everything, it takes about 1 month. Now coming to gingivoplasty, it is reshaping of the gingiva to create physiologic gingival contours with the sole purpose of recontouring the gingiva in the absence of pocket. This we have already discussed in the beginning of this lecture. The gingival and periodontal diseases often produce deformities in the gingiva that is conducive for plaque accumulation and food debris, which prolongs and aggravates the disease process. Such deformities include gingival clefts and craters, or crater-like interdental papillae. Gingivoplasty may be accomplished with a periodontal knife, a scalpel, or diamond stones or electrodes. The technique resembles that of festooning of an artificial denture, which consists of tapering the gingival margin, creating a scalloped marginal outline, thinning the attached gingiva, creating vertical interdental grooves, and reshaping the interdental papilla. So you basically try to mimic what the actual healthy gingiva looks like in this procedure. So this is the end of Samdar. Thank you everyone.